Okay, now let's talk about pre-anesthesia testing. What is pre-anesthesia testing? It is the clinic designed to help prepare patients for surgery or procedure requiring anesthesia. So why do patients need to go PAT? Because more and more surgeries are done on outpatient basis, like the surgeries that traditionally required inpatient stays, like your total joints, hysterectomies, and stuff like that. They are done on outpatient basis. And nobody has time, right? Nobody has time to properly screen the patients in pre-op. Have you ever been to pre-op? They are so busy. They have so many things to do. And imagine that on top of the list they have to do. The patient who has multiple medical history, like your aging population, right? They're on so many meds and try to get their histories right and medication right. It takes time and they have so much things to do. And we don't have time to properly screen the patients in pre-op. And the patient's acuity is higher. You probably feel that in your area you work in, even in outpatient setting. So safer, more efficient care on the day of surgery helps to prevent day of surgery cancellation or delay. And periop is all about throughput, right? We want to make sure we can get the patient moving from point A, point B, point C smoothly, right? So we can keep the OR going. So we are like a well-oiled machine. Make sure we have nothing that is stopping away. So it's really important that patient gets screened beforehand so we can move everything efficiently. So I said earlier that trend in surgery, more complex surgeries are done on outpatient basis. For example, total joints, hysterectomies, prostate surgeries, laparoscopic GI surgeries, spine surgeries, they're all done on outpatient basis. So we need to make sure we can put the patient under anesthesia safely. So how does PAD help? It prevents a delay on the day of surgery that results from missing information like COVID screening information. That's so important, right? The patient maybe had some fever a couple of days ago. Did you get screened for COVID? That's information you do need to know, right? That is going to really delay your surgery if you needed to swab the patient in the pre-op. Cardiac clearance. So the more patients having a cardiac disease coming to surgery, like heart failure, patient may had an MI recently, those patients, you will need cardiology clearance before we put them under anesthesia. Because think about it, anesthesia and surgery, that's a stress on the heart. And we don't want to have a complication on the table. So we want to make sure the patient's clear beforehand. Do we have adequate labs? Do we have, for example, patient may be taking some sort of anticoagulation? Do we have a PT, INR, and all that stuff? Type and screen. It's like the worst thing. You draw your type and screen on the morning of surgery, right? And the lab calls you and say, hey, your patient have a lot of antibodies. It's gonna take hours before I can get the result back to you. That is really going to delay your surgery. So we need to make sure that it's done beforehand. So let's look at those three patients. We have patient 1, 2, 3. And which patient do you want to pre-op? We have patient 1. She is having ACL repair. History of congenital heart defect, multiple cardiac surgeries, systolic heart failure with an EF of 25%. I don't know if I want to pre-op this patient, want to find all that information. Or when was the last echo? What did your cardiologist say? What medication are you taking, right? So it's really important this patient went to PAT. I get screen say, hey, I'm going to stop the line right here. You need to go see your cardiologist and then here are all the labs and diagnostic you need to have beforehand before we can put you under anesthesia. So let's look at patient 2. She is coming in for scheduled C-section. Sounds simple enough. But her history, oh my goodness, pulmonary hypertension on epoprostenol infusion. Oh, I need to make sure I coordinated with pharmacy, right? This is an infusion you do not want to interrupt, and the cassette needs to be changed every 24 hours, and it's a specialty pharmacy. We want to make sure we have everything on hand. We are ready to care for this patient. So again, this patient is something that you don't want to find out on the morning of. What about patient 3? He is coming in for cholecystectomy. History of type 1 diabetes, frequent DKA admission. Oh my goodness. And the last admission, he was admitted 3 weeks ago for DKA and pancreatitis. Oh, I don't know if I want to pre-op this patient on the morning of either, right? Without having adequate lab, make sure his endocrinologist was involved in the care and his medications are straight. Did you hold your medication or did you continue your insulin? You need to know all that stuff, and the patient needs to be educated beforehand. So he won't go in DK after surgery, right? So all of those patients would benefit from going to PAT. So more benefits of PAT. It's safer. So the patient could get a medical clearance, cardiac clearance, all the clearance they need to safely go under anesthesia. Labs, diagnostic, type and screen, review of systems, medication review. Some medication needs to be continued on the morning of. Some medication needs to be held a few days before, maybe a few weeks before. So if the patient didn't know that and keep taking those medications, they could bleed out on the table and or clotting issue after surgery. So we need to know what medication they're taking, and that some medication maybe needs to be held. And the patients are more informed, so they would know more about anesthesia options. So orthopedic surgery, they're very painful, right? And if they know beforehand, we have an option to do nerve block. And so you take less pain medication. And so they'll be more informed. And day of surgery expectation, like where to park, where the registration is, where the pre-op is located, and stuff like that. An overall expectation plan of the surgery. So some patient needs to know, yes, I need to have appointment on the in that afternoon, or I will have a PT the following day and whatnot. So they would know and what diet they need to be on. Registration and insurance clearance, this takes some time. So it's really nice to go ahead and get that out of the way. And so you don't delay the surgery on the morning of. And patients are educated. They know about ARS protocol. So they might be given some nutritional supplement so we can optimize their muscle strength and their nutrition before they come into surgery. Medications are optimized. Some, like I said earlier, some medication needs to be held. And the post-op education can be started early on so they would know what to expect day by day. And the infection prevention, like bathing instruction, can be given in a PIT. So it's really important that they go, and it's so beneficial to the patient, any patient, to be honest. Okay, so let's talk about some of the medications. I keep saying that optimizing medication, right? So let's talk about the medication evaluation to optimize patient outcomes. So I do want to talk a little bit about cardiac medications, pulmonary medications, endocrine medications, central nervous system medication, GI medication, renal GU medication. So this is just a general talk, and almost all the medications are held or continued on individual basis. But some of them are skip measures, so I do want you to pay attention to that. And these questions almost always pops up on your CPAN or CAPA exam. So review those slides if you are thinking about taking your CPAN or CAPA certification. Okay, so let's talk about cardiovascular medication, like your beta blockers. So that's your LOLs, right? The funny ones, your metoprolol, atenolol, and stuff like that, LOL, right? And what are the indications for beta blockers? For your chest pain, arrhythmia, heart failure, hypertension. This is a part of skip measure. They need to continue taking this medication even the morning of. Not continuing to take beta blockers result in increased incidence of post-op MI. So that's why it's really important. And you probably heard anesthesia asking, do you take beta blockers? Okay, you take metoprolol. Did you take one this morning? And if not a big deal. We can give it IV. So make sure if the patient's on beta blockers, ask, have you taken it this morning? When do you usually take? Have you taken this morning? It's really important. Abrupt discontinuation may result in rebound tachycardia, angina, and hypertension as well. So they must continue to take even on the day of surgery. So this is important. This is a biggie. Beta blockers must be continued. Alpha-2 agonists, like your clonidine, and it is for your hypertension, right? they should be continuing to take those medications. Why? Because it can cause rebound hypertension. So let's say the patient takes clonidine every 8 hours, and they were just instructed like a generic blanket statement, stop taking all your medication the night before. If they skip, let's say 2 doses, they can have a rebound hypertension, come to you pre-op with a really, really high blood pressure, and patient can have a stroke. So it's really important they continue that medication and educate it in a PAD. What about calcium channel blockers? That's like your cardizem, procardia, and stuff like that. Indications for your hypertension, CAD, and withdrawal syndrome is not typical, but abrupt discontinuation may cause severe vasospasms. So it is recommended that you continue taking that medication. Digoxin, and generally speaking, just continue taking it. Usually pre-op drug level is not necessary, and IV form is available if the patient forgot to take it the morning of. So let's talk about the one that makes patients bleed, antiplatelet therapy, like your Plavix, right? Or Integralin. And indications for your acute coronary syndrome, AFib, and it's an antiplatelet therapy, right? Antiplatelet against platelet, right? Time to sufficient drug eliminations are listed here for your reference. So some patient might be asked to hold the aspirin for 7 days. So it is out of their system. And all of those antiplatelet, anticoagulation therapy are done on individual basis. So they will think of anesthesia and surgeon, they would think about the risk versus benefit. And do I want to clot this stent in the heart to repair ACL? And you're not going to bleed out from ACL surgery, and more than likely you're not going to bleed out. So they're probably going to continue the antiplatelet therapy. So they'll think about the risk versus benefit. So anticoagulant therapy is the same way, like your Coumadin and a Pradaxa. That's a lot of the patient takes all those medications, right? Indication AFib, VTE prevention, and treatment for that. Time to sufficient drug eliminations are listed here. For important ones, heparin. So that's your inpatient surgeries, right? The patient coming from inpatient unit on heparin drip. They typically hold about 4 to 6 hours to kind of eliminate the drug from the system, so patient won't bleed out. But again, it is risk versus benefit. So if the patient, let's say, have an active DVT, they don't want to have them to have another DVT and whatnot, or clot get bigger. So they might continue that heparin drip. So it's really case by case. Okay, cholesterol lowering medication. Statins are usually taken at night, right? So they will continue taking that as statins, and they can take it the night before. It's not a big deal. One thing about cholesterol lowering medication, statins called by niacin, that needs to be held. Why? Because that adverse risk of a myopathy may be increased with some of that anesthesia agents. So they typically ask the patient to hold niacin. But niacin, think about it, that is, you can buy that over the counter, right? And that can help lower cholesterol, but it's a longer term thing. It's a very slow acting thing, right? It's a long term, okay, your cholesterol is a little bit high, I need to lower that. So take some niacin, right? And so it's like a long term, and then it's not going to kill them if they hold that niacin for a few days or even for a few weeks. Nitrates. So if they're taking nitrates for like angina, withdrawal if you stop taking them, they can cause rebound coronary vasoconstriction and worsening chest pain. So they need to keep taking them if they take this on a regular basis. So let's summarize CV medication usually held on the day of surgery. So niacin, like I said earlier, and fibric acid derivatives, they have adverse risk of myopathy with some of the anesthesia agents. So they are typically asked to be held the day before. And ACE inhibitors and herbs, this is a surprising one. So they usually ask to hold this medication. So they can still take it the night before, but these causes concern for excessive intraoperative hypotension. And so they might be asked to hold that medication on the morning of. But again, it's really case by case. So for example, if the patient have a really poorly controlled hypertension or pretty bad heart failure, and they need to be taking them, they might be taking them, and anesthesia provider will just manage the intraoperative hypotension. So it really depends. And usually they are given instruction like to hold it if the unless the systolic blood pressure is greater than 180 or diastolic greater than 110 or something like that. And a diuretic. This one makes sense, right? You want to hold it on the morning of because they've been NPO, and even they can drink clear liquid up to 2 hours before. They usually kind of come in hypovolemic anyways. So we don't want them to lose additional fluid, and concerns for hypokalemia and hypovolemia. So we don't want that. And that can really put the patient at risk for arrhythmia during anesthesia too. So these are the medications typically asked to be held on the morning of. So to summarize, okay, so beta blockers, are we continuing before surgery? Yes, we are. What about day of surgery? Are we asking them to keep taking them? Absolutely. This is one of the skip measures, right? You want to make sure they keep taking beta blockers. What about ACE inhibitors and ARBs? Continue taking before surgery? Yes. But this is one of them. Remember, they might be asked to hold on the day of surgery. Again, case by case, but generally speaking, they're asked to hold on the day of surgery. What about nitrates? Please keep taking them, right? We don't want to cause vasospasm or pulmonary worsening chest pain, and take it on day of surgery if needed. What about alpha-2 agonists like clonidine? Keep taking them? Absolutely, yeah. Yeah, you want them keep taking them, right? Okay. What about aspirin or anticoagulants? So think about those. These are case by case. So some patients might be asked to keep taking them. Some patients say, hey, just hold it for a few days or whatnot. What about diuretics? I already gave you an answer here. Continue taking before surgery the night before? Yes, absolutely. What about day of? No. You typically ask them to hold, right? Okay. What about statins? We ask them to take it the day before, right? That makes sense. If it's some reason they take it in the morning, they can continue it, but usually take it at night. So they take it at night before. What about niacin? Do you remember that one? And can they continue taking that before surgery? Yes, they can. What about day of surgery? That's the one we ask them to hold. So, and it's a risk for myopathy. So we ask them to hold on the day of. What about antiarrhythmic? We didn't really talk about that, but use your brain. Think about it. Do you want your patient to go in arrhythmia? Absolutely not, right? So we want them keep taking them. That's your amiodarone and stuff like that. So the patient are at risk for arrhythmia with anesthesia anyway. So we don't want to increase the risk by asking them to hold antiarrhythmics. All right, let's talk about the GI medication. So that is your H2 blockers and PPI, like your Zantac, Nexium, all that stuff for your GERD, yeah. We don't want the patient having GERD, so please, please, please continue taking them. There, you need it. So that is your GI medication. Pretty simple, straightforward. What about the pulmonary medications? This is simple too. You don't want your patient to have asthma attack in the PACU, do you? No, right? So like your beta agonist, like your ProAir, like your albuterol, anticholinergic, like Atrovent, Spiriva, it's your bronchodilator. It's for your asthma, COPD. Please keep taking them. Often we ask them to bring the inhaler with them to the surgery, and they take a couple puffs before we put them on there. Theophylline, what about those? So there's no data indicating continuation of theophylline in a period decreased pulmonary complications, but it has a potential to cause serious arrhythmias and neurotoxicity at a level just beyond the therapeutic range. So we asked them to discontinue the evening before surgery. So that's one of them that we asked them to stop before. What about corticosteroids? We don't want to stop the medication abruptly, right? For any reason. So they need to keep taking them. Okay. What about prostaglandins like your epoprostenol? The abrupt withdrawal can be lethal. rebound pulmonary hypertension can kill the patient. So absolutely continue this medication, and they need to bring a backup pump and your exchange of cassette. So that way, usually they change this cassette out every 24 hours. It could be like 2 in the afternoon or whatnot. And these are sent by a specialty pharmacy. So if you run out and you call your normal pharmacy, guess what? They won't have that. So we need to make sure we arrange that beforehand. So that's really, really important. Okay, what about endocrine medication? An oral agent or non-insulin injectable medication like your metformin and whatnot. And so they typically continue until the morning of surgery. And some of the medication can interact with contrast. So it's really important what sort of procedure they're having. So if they are planning to do some sort of diagnostic beforehand and needing a contrast, that might need to be held. So that's why it's really important we go to PAT, right? What about insulin injection? What about insulin pump they come with? They can continue with their usual infusion rate, or sometimes they cut in half. Again, it's so important to consult endocrinologists and make sure we are not putting the patient on hypoglycemia, and those patients need to be monitored, right? Basal insulin, reduce dose per endocrinologist. So again, it's so important to get the expert involved. Okay. All right, so corticosteroids, again, it came up again, right? Here are the potential adverse effects of therapeutic glucocorticosteroids. This pops up in a CPAN exam, but it might pop up in a way that can be really tricky. So you could get a question like, okay, your patient have Addison's disease, and anesthesia provider gave corticosteroid in IV, right? What are the potential adverse effects of that medication? So you could ask something like that. So it does pop up, and it does impair wound healing, increase the skin gets more fragile, and the vessel gets more fragile, right? And increased risk of fracture, infections, and GI hemorrhage or ulcer, hypoglycemia, hypertension, and fluid retention. So again, it's individualized approach, but do not abruptly discontinue this medication. What about oral contraceptives? So we typically ask them to continue taking the medication, but one thing they need to be aware of, so if the anesthesia provider have given Gamadex to reverse neovascular blockade, you need to give instruction for them to use an alternative contraceptive method for at least 7 days. So that's one important thing if they're taking that, but they can keep taking them. It does increase the risk of thrombosis, so that's another thing to be aware of too. Thyroid medication makes sense, right? Continue. Why would we stop, right? So really continue. T4 can be given IV or IM as well, so if they miss a dose. Osteoporosis medication, what about those? So it really depends. Some of the medication can cause osteonecrosis of the jaw, and a patient going like a dental surgery. So that has to be held. Again, you would not know all these things and what it could do to depending on what kind of surgery they have. So that's why it's so important they go to the pre-anesthesia testing. So you don't have to think about this in the morning of. Typically, we ask them to hold the morning of surgery. The reason why we ask them to hold on the morning of surgery is because they need to be taking with at least 8 ounces of water. That's way too much, right? We don't want them to be drinking that much water like before surgery and they aspirate. So we typically ask them to hold the medication in the morning of. So let's talk about the central nervous system medication, like your anticonvulsants. Oh my goodness, please do continue them. And most of those medications are available in IV form. So if they do miss a dose, let the anesthesia know, right? So we can give this dose in IV. So continue. We don't want this patient having a seizure post-op or during a procedure. What about anti-Parkinson medication? So this is, again, another one that is kind of case by case. but it should not be withheld in most circumstances. Abrupt withdrawal anti-Parkinson medication may lead to flares of Parkinson syndrome, but some of that surgery will require them to be like a little bit lower dose. So they might work with a patient to reduce the dose or taper before surgery. And if they are not being that way and didn't taper, maybe they continue the medication, the first thing they're going to ask in the PACU is, guess what? Can I take my anti-Parkinson medication? So make sure you give that dose in the PACU. Okay. MAOIs. So, I forgot to mention one thing. So anti-Parkinson agent. So one exception to this anti-Parkinson medication, they do hold this medication if the patient is having deep brain stimulators. That's one exception. And they try to taper, or they might just continue the same dose because we don't want them to have symptoms, right? But they will hold the medication for deep brain stimulators. I forgot to mention that. I'm sorry. MAOIs, this interacts with everything, right? If you went through nursing school and have a drug-drug interaction with MAOIs, so many of them. And so the decision to continue with hold non-selective MAOIs before surgery requires close collaboration with anesthesia provider and psychiatrist. Typically speaking, they would ask the patient to discontinue 2 weeks before surgery. TCAs. And so that is your Elavil. Most textbooks and journal recommend continuing taking those agents in a period setting, and it's said to be pretty safe. And so FDA, on the other hand, advised that TCA should be discontinued prior to elective surgery due to increased risk of arrhythmia and delayed gastric emptying. But a lot of the journals are not citing that. So, but again, FDA is saying that. So just the one thing to be aware of. SSRIs, they do ask the patient to continue taking. Again, we don't want the patient to abruptly stop taking SSRI, right? They can have an increased suicide ideation and stuff like that, exacerbation of mood and other disorders. So we want them to continue taking SSRIs. What about anti-anxiety medications? So if the patient is anxious in the pre-op and they go under and they wake up in the PACU, they are 10 times worse in the PACU. So we would want them to absolutely continue taking their anti-anxiety medications like your Xanax, or Valium, Clonopine, Ativan, whatever that is they're taking. And if they hold that medication, and if they take it on a regular basis, they can have withdrawal symptoms. So they need to continue taking the medication. What about psychostimulants like your Adderall or Ritalin? And what about those psychostimulants, ADHD medications? What do they need to concentrate on after waking up from surgery? They need to do math? No, they don't, right? So stop. They don't need to take that medication. They can continue after the surgery. What about mood stabilizing agents like your lithium? Lithium is already tricky to make sure you're in a therapeutic range, right? So we ask them to continue taking the medication. Lithium can prolong the effect of muscle relaxant. So that's something you need to be aware of. So if the patient was intubated, they had a muscle relaxant, their effect might be prolonged, even if we reverse them. So really watch that too. And another thing, be aware of a volume hypovolemia and electrolyte status. Lithium is infamous for causing sodium disturbance. So it's really important to know that. What about antipsychotics? Oh my goodness, please keep taking them, right? You don't want them to have symptoms in the PACU. And most of those antipsychotics can prolong QT interval. So be aware of that medication they're taking, and your medication that you are giving, like your Zofran, can prolong the QT interval and can put the patient into torsades. So it's really aware. If it's too long, Zofran might not be the drug of choice. And antipsychotics may potentiate the sedative and hypotensive effects of anesthetic and opiates too. So another thing to be aware of. What about analgesic medication? So like your NSAIDs. So NSAIDs like your ibuprofen, it is again case by case, but typically speaking, they ask the patient to stop taking them 4 to 5 days before surgery. Aspirin, if they're taking aspirin for pain, they ask the patient to stop taking them. Remember, the elimination time for aspirin is about 7 days, so at least a week prior to surgery. If they're taking aspirin for other reason, like your anti-platelet therapy, that's another conversation. This is for pain, like your headache and stuff like that. What about opiates for chronic pain? Please keep taking them. You do not need the patient to have withdrawal, or you don't want to be behind on the pain management, right? So if they are taking pain medication on a regular basis, and they, let's say, stop taking them, let's say a few days before, because you are they are instructed to, and they come to pre-op already in 10 out of 10 pain, you already way behind in the PACU, you may not be able to control the pain. So they need to continue taking that. What about some of the medication they take for addiction of opiates? So we asked them, it should be discontinued in anticipation of surgery. Thus, decrease craving and helps maintain the abstinence of opiate-addicted patient. It's also used for treatment of alcoholism, but we asked them to hold the medication because we are probably going to give some opiates, right? And those medication is competing at the receptor side and making the medication less effective. And if we need to give it, we can give it an IV, and we can give it an PO as well. So let's talk about herbal supplements that a lot of patients taking nowadays. So it's natural, so it must be safe, right? Is it? Well, patients may not tell you what they take either, right? So you ask about what medications do you take, and they'll tell you all about the medication they prescribed, but they're not going to tell you about the medication they take over the counter. And so you need to ask, do you take any supplements for anything, maybe a joint pain or vitamins too. So that's something you need to ask. There's no evidence that herbal medications improve surgical outcomes. So we must specifically inquire about herbal medication use. And some can cause clotting abnormalities and have an interaction with anesthetics. And here are the 8 commonly used herbal medication and what you need to know about those medication or herbal remedies. And I think when I took my CPAN exam, I may or may not ask about this, so review those. Ephedra can increase the risk of minor CVA, so it needs to be discontinued at least 24 hours prior. But the rule of thumb is for herbal remedies, they should stop like 2 weeks before. What about garlic? And my dad was taking garlic for his cholesterol level, and it does increase bleeding risk. So it needs to be continued at least 7 days before surgery. What about ginkgo? An increased bleeding risk here as well, and it needs to be discontinued at least 36 hours prior. Ginseng, it does lower blood sugar and increase the bleeding risk, and needs to be discontinued at least 7 days prior. Kava, it increases the sedative effect of anesthetic, so it needs to be discontinued at least 24 hours prior. And also some reports about a fatal hepatotoxicity with use. So we give a lot of medication that is pretty heavy on like a liver elimination, so really be aware of that too. St. John's wort diminished the effect of several drugs. So needs to be continued at least 5 days before surgery. And so look, if you're looking at all of those things, it can affect, it interact with anesthesia, will cause bleeding risk. That's still no good, right? So really, those herbal medications should be held at least 7 days, and if not 2 weeks beforehand. Here are my references, and thank you for listening.